controversies to the consensus in the management of hypertension, which is very challenging actually. But this is one disease, hypertension, which all of you are involved in treating it in some way or the other, and many of you or your family members must be suffering. And we keep on encountering such controversies day in, day out, and hence it becomes more challenge to take on the treatment and the management aspect. So let me take you to my outline presentations of the talk. I'll be very briefly addressing about the history of the BP measurement, because it has been a great innovation. So if you look back to the years how it has evolved, the ambulatory blood pressure monitoring, the Indian scenario of the hypertension, the guidelines of the hypertension, the similarities and differences, the recent trials and the practical implications, particularly addressing the SPRINT and the HOPE-3 trial, which has come up with the recent advances, the special cases like management of hypertension and diabetes and CKD, the chronopharmacology, and hence I will be concluding with all the controversies that has been in the recent past. So as of you know, the entire BP measurement depends on the technique. And if you look at how it evolved, it was Stephen Hales who first measured the blood pressure, and it was measured from the height of a column of the blood after cannulating the carotid artery in a horse with a brass pipe. And you look at the technique. This brass pipe was attached to a 12-inch glass tube, and the tube was connected to a pipe via the trachea of the goose. And look at the way you are sitting on your office, measuring your blood pressure, and look at the era how it started with. And the second try, almost 100 years later, came the mercury manometer connected to the artery, which was used to measure the blood pressure. However, these methods were very invasive and hence very uncomfortable to the patient. What we are doing in a recent way, the technique that has evolved from Rivarossi, who invented this sphygmomanometer. That is sphygmo meaning pulse, and the manometer is the pressure meter. This consisted of a mercury column, a rubber sleeve is filled with air, a squeeze bag, and to inflate the rubber tube. Currently, this method is also been replaced by non-mercury system, which you all are using. But as Kaplan, who is the world authority in the hypertension, if you look at, he commented, the measurement of the blood pressure is a clinical procedure of greatest importance, and that is performed in the most sloppy manner. So it is the method with which you measure the blood pressure becomes the crux of how you are going to treat it. And just to highlight this, look at the Indian guidelines. There should be an average of 3 readings taken at intervals of 2 to 3 minutes. It should be recorded. Before that, the patient should be asked to refrain from smoking or drinking tea, coffee, or do any exercise for 30 minutes prior to the measurement of the blood pressure. We should allow the patient to sit at least for 5 minutes in a quiet room before beginning of the blood pressure measurement, and it should be done preferably in a sitting or a supine position. Patient's arm should be fully bared and supported at the level of the heart. The measurement should be done in the first visit in both arms, and the higher of the 2 readings are to be used. Concomitantly, if you have a difference of the pulse between the both upper arm and the lower arm, you should also record the lower arm pressures. Why it is important, the key technique, look at this. If the patient is not quietly rest and you record the resting and the patient when has walked to your clinic, there might be a difference of 12/6 millimeter of mercury. If the patient is not seated with adequate back support, again your pressures may be falsely elevated. If your cuff is not at the at the mid-sternal level, again there are fluctuations of 2 millimeter per inch of the variations. If you are not measuring with the correct size, that if the size is too small, you might record higher blood pressure. If it is too large, you'll record lower blood pressure. And if the bladder is not centered over the artery, again there are variations of about 3 to 5 millimeter. If you not deflate at an adequate speed of about 2 millimeter per second, again you might falsely get higher or lower blood pressure. So there should not be any discussion or talking while measuring the blood pressure. That is also very important because it falsely elevates the blood pressure. So if the initial blood pressure is more than the goal of the blood pressure, you should always look at the first higher reading. So when you record, it should be 3 readings 1 minute apart, and we should ideally discard the first reading and take the average of the last 2 readings. So this is very important, and the whole process, if you look at, it takes about 8 to 11 minutes. And some of you who are very busy practitioners might see 3 patients in that 8 to 10 minutes time. So it is very important that how you measure the blood pressure, because it classifies the patient accordingly, and you'll be treating such patients lifelong with medications. One of the important features is the ambulatory blood pressure monitoring. And here, instead of a static reading, you tie up the blood pressure curve. There is an instrument which keeps on inflating every half an hour during the daytime or every 1 hour in the night time. Or if you want to customize, it will record in accordance to the customized reading. And this recording goes on for the next 24 hours. And this entire tracings are planted out, and then you can interpret accordingly. So it correlates more with the, the patient's day-to-day variations in the blood pressure, and hence it correlates more with the target organ damage rather than your single reading at the office. So ambulatory blood pressure monitoring can also, identify those patients who are non-dippers. Means normally the nocturnal variations are there, where the nocturnal pressures are less than the daytime pressures. So those who do not have this dip in the night pressures, non-dippers, they are at more risk of cardiovascular mortality than others. So the indications of ambulatory blood pressure monitoring, which we sparingly use actually, and currently in our center also we are using it more and more often, because it helps you to identify the borderline hypertension patients. It helps you to identify the white coat hypertension, the isolated systolic hypertension, the nocturnal blood pressures, those who are resistant hypertension. Then again, important subgroup of patients, pregnant ladies coming to you who might be, your office reading might be high, but the actual readings may not be high. To establish hypertension, again in those class of patients, is very important that ambulatory blood pressure monitoring symptoms should be there. Again, lastly, there are certain patients who have symptoms which are suggestive of hypotension, and again these patients should also be subjected to ambulatory blood pressure monitoring, so that you can identify the dips and the fluctuations, the peaks and the nadirs. So recommended levels for the blood pressure, the normal readings ambulatory. Awake pressures, if it should be ideally less than 130/80 optimally. Normal, the cutoff values are 135/85, but if it is more than 140/90, again they are labeled as hypertension. While the sleep pressures, they are labeled at optimally, it should be less than 115/65. Normally it should be less than 120/70, and again if it is more than 125/65, they have a tendency to have hypertension. But again, there are certain limitations of ambulatory blood pressure monitoring, and these intermittent measurements during which the individual is sedentary rather than ambulatory, that makes it difficult. The technique again is a very challenging. Many of the patients feel very uncomfortable, and I have seen one patient even within an hour or so, they're coming back, doc, I don't want this measurement, please do something else. So it might be sometimes very uncomfortable. Expensive, perhaps not, but in Western countries, yes. In our context, it is not very expensive test. Takes you only about 1,000 rupees for the entire course of the measurement. So what is the Indian scenario for the hypertension? So if you look at, the prevalence rate is nearly about 30%. Most of them in the urban, where it varies from 30 to 35%, and rural about nothing, no less figures, it varies from 25 to 30%. The trends, those who are over, if you look at the trends in the last 50 years, between 1945 and 1995, there was much steeper increase in the prevalence of hypertension in urban population than in the rural population. So if you look at the urban prevalence, overall, there is 33.8, rural 27.6. If you look at the patients who are aware of their hypertension, urban people are more aware. This is awareness, so is 41.9%. Rural, they are less aware. Those patients who are taking the treatment for hypertension after being aware is about 37% in the urban areas and only 25% in the rural areas. And those in whom BP is under control is mere only 20% in the urban and only 10% in the rural. So these are decimally poor figures where you have optimally treated patients where BP levels are controlled, only 20% in urban areas and 10% in the rural areas. So despite all efforts, the level of awareness in India is still very low, and this is also evident with lower proportion of the patients achieving optimal control. So what are the guidelines that we have? So we have various guidelines, the JNC 8, the European Society recommendations, and losartan was found to be more effective than atenolol in reducing the cardiovascular mortality and morbidity as well as the all-cause mortality. Well, if you look at the ASCOP study, the fatal and the non-fatal stroke, the total cardiovascular events, the procedures and all-cause mortality, that was much lower in the amlodipine-based regimes than the atenolol-based regimes. There are certain newer beta blockers with vasodilatory actions like nebivolol. They do not share some of the limitations of the traditional beta blockers, particularly the atenolol. There was another study by Kim group, and they suggest that among the third generation vasodilating beta blockers, that is nebivolol, may be particularly suitable for as a first line treatment for hypertension in certain kind of patients. So it may be timely for the treatment guidelines to recommend the third generation vasodilatory beta blockers as the first line options for hypertension. Although this is not a very big study, but a small study. So coming to two recent trials which has been published, that is the SPRINT study and the HOPE study. Let us take one by one. The first one is the SPRINT study. Now here in the SPRINT, the primary hypothesis was the composite cardiovascular event rate to be lower in those with intensive therapy. Intensive therapy means where you reach the goal of less than 120, compared with standard therapy where you reach the goal of 140, less than 140 in non-diabetic population. And the primary outcome they studied was the composite outcome of myocardial infarction, the acute coronary syndrome, the stroke, decompensated heart failure, and cardiovascular deaths. Now, if you look at the graphical representation here, the blue one stands for the standard treatment and the golden one stands for intensive therapy. Now, intensive arm had 25% less incidence of cardiovascular events, and the number needed to treat was only 61. So if you look at the safety outcomes, the hypotension and acute kidney injury or acute renal failure was slightly more in the intensive group than in the standard group. Particularly the acute kidney injury, it reached a significant p-values. So the conclusion was the treatment effect was similar in all 6 pre-specified groups of interest based on age, sex, race, baseline, systolic blood pressure, history of cardiovascular disease, and history of CKD. Overall benefits were more common in intensive blood pressure lowering, and it exceeded the potential, the possible potential for harm in way of hypotension and acute kidney injury. Now, what is the implication of SPRINT trial in our practice? At each visit, the patient in the SPRINT study were seated in a quiet area for 5 minutes. Then blood pressure was recorded by commercially available automated units, and they recorded 3 readings separated by several minutes, and there was no clinician in that room. So, and the decision were based on the average of 3 readings. In other studies, they have shown that this method of BP measurement is substantially lower readings than does the single rushed measurement typically in many of your practice. So this was the controversy in the SPRINT trial. The way the measurement method was less than perfect, and nobody measures the blood pressure in the way in the SPRINT trial was measured. So if SPRINT trial is applied without attention to proper blood pressure measurement, there might be substantial over treatment and with a higher rate of adverse event which is likely to be anticipated with the use of potential drugs. So therefore, I don't think the relevance of sprint trial is there in day-to-day practice. So should the guidelines change for the stringent target blood pressure of 120 as evident from the sprint trial? Now the average systolic blood pressure achieved in the sprint trial by intensive therapy was 121 and it remained higher than the 120 target. This likely represents judicious balancing by treating the clinician who tried to approximate 120 millimeter while avoiding the side effects. So clues to the drugs used in this study: chlorothiazide, which was used in a dose of 12.5 to 25. It was a thiazide type diuretic, which is drug of choice, diuretic of choice for this trial. It's more potent and longer acting than hydrochlorothiazide. Amlodipine was the calcium channel blocker of choice. Beta blockers, now considered to be less effective in preventing cardiovascular events as primary treatment of hypertension, but may be needed in persons with coronary artery disease. Another trial, this is second group, that is HOPE-3 trial. We were also participant of the HOPE-3 trial in our center, and the hypothesis in this was among patients with intermediate cardiovascular disease with normal or lower BP, do they need antihypertensive to reduce cardiovascular events? There were a couple of co-primary outcomes in this, that is composite of death from the cardiovascular causes, non-fatal infarction and non-fatal stroke, resuscitated cardiac arrest, heart failure and revascularization. Now if you look at here, the placebo versus the arm, the treatment arm consisted of use of hydrochlorothiazide with candesartan, and if you look at both of the line runs in parallel. So there was no significant difference in the individual components of the outcomes of total mortality or new onset diabetes. Again, if you look at here, this is death from the cardiovascular events, myocardial infarction, stroke and cardiac arrest, there was no difference. So in this subgroup, it was found that those with in the upper one-third of the systolic blood pressure, that is those who were having blood pressure of more than 140, the active treatment group had nominally significant lower rates of outcomes rather than placebo. So in this study, it was emphasized that those who are in the higher level, they were benefited more rather than those who were harboring low blood pressure, that is around 120 or 130. Again, an interesting subset analysis in this study was addition of statins did lower the overall cardiovascular benefit. So again, it emphasized on the BP measurement protocol. If you look at here, the manual measurement and the automatic measurement, it was detailed, almost the way the guidelines propose. So a special attention was emphasized in this trial about the way to measure the blood pressure. So the comments from the HOPE-3 authors, their finding contradict the fact that the lower is better hypothesis. So their data were compatible with the hypothesis that treating persons without cardiovascular disease who have a systolic blood pressure of 140 appears to be beneficial, but treatment would not be benefit and even harmful in those who are having a blood pressure of less than 140. Let's look at some of these special subsets, that is patients with hypertension and diabetes and chronic kidney disease. So in this ACCORD blood pressure trial, if you look at nearly 5,000 patients were treated, they had a little bit of proteinuria, creatine levels were not markedly elevated. And again, the systolic blood pressure was either in two groups, less than 140 or less than 120. Again, it was a randomized controlled trial of the control of glucose and other factors. If you look at here, targeting systolic blood pressure less than 120 as compared to less than 140 did not reduce the rate of composite outcome of fatal or non-fatal cardiovascular events, meaning thereby you need not reduce your blood pressure levels to much lower as compared to slightly accepted less than 140. So what should be the goal? If you look at here, the various guidelines, for a normal general population, it is again 140/90 for those who are younger, and those who are elderly 150/90. Those with diabetes again or kidney disease, the target remains less than 140/90. But if proteinuria is there, again one of the guidelines they emphasize it should be less than 130. The KDIGO guidelines also says that it should target to less than 140/90 in those who do not have albuminuria, but it should target less than 130 if the albumin excretion exceeds more than 30 per hour. So this is the KDIGO guideline, and again here the aim is to target for less than 130 if albuminuria is present. And the last emphasis on the controversies today is the chronopharmacology. That means what should be the timing of administration of the antihypertensive drug. And it's a very, very controversial thing. Some of you prefer giving it morning tablets, some of you prefer prescribing it in the evening. So let us look at the trials. The MAPEC trial, this is a 48-hour ambulatory blood pressure which showed a lower systolic blood pressure with use of evening doses. However, interestingly, with such evening dose, you had lower risk of total cardiovascular events, that is cardiovascular death, MI and stroke. The TIME trial, again this is, the results are expected to be out in 2019. It has recruited more than, targeted to recruit more than 10,000 patients with primary endpoint of hospitalization for composite endpoint, and we will have to watch again what this trial suggests for the timing of the drug. HIGA trial, again morning versus evening, to investigate the comparative prognostic value of several blood pressure parameters in the prediction of vascular, metabolic, renal morbidity and mortality, and whether the potential changes in the circadian BP pattern after the treatment of hypertension medication may be associated with changes in the risk of cardiovascular events. Again, this trial is expected to be completed by 2020. We have to wait and watch. However, at this point of time, morning versus evening, the controversy still remains. And if you look at the Cochrane review in 2011 to evaluate the time-related effects of antihypertensive administered as once daily monotherapy in evening versus morning regimes, there are no randomized control reported on the clinically relevant outcomes. There is no significant difference in overall adverse events and withdrawals. Blood pressure control, however, with bedtime dosing, the clinical significance is not yet known. So still the controversy rises whether it should be given in the morning or evening, and we continue with most of us giving a morning medication, but some of the trials have showed evening doses might be better. So to conclude my talk about the controversies, hypertension remains one of the most important public health related issue in India. The methodology to measure the accurate blood pressure should be given the due importance. Ambulatory blood pressure monitoring is a useful tool in certain conditions. Recent trials have provided useful information of lowering the BP further, that is the usual goals of the BP yet to be followed, and we don't have evidence to support the sprint results from other trials. The blood pressure goals can be lowered further in some special conditions, like for example in CKD with albuminuria. The choice of drugs for controlling blood pressure should be individualized. Till more data emerge, evening dose of antihypertensive therapy can be advised, and it is high time that in India we should have own trials to assess the cardiovascular outcomes in patients with hypertension by use of various drugs. Thank you.